Thank you, Dr. Howell and Dr. Herrera, who was part of this group that got together from the College of American Pathologists. I hope you can hear me. I developed a bit of a cold thanks to the airplane, most likely. Don't want to share it with anyone. So I'd like to make you feel good first before I make you feel a little bit bad about the day-to-day use of VM in amyloidosis. How ultrastructural analysis has contributed to our understanding of the disease. Why did the CAP decide all of a sudden to create a guideline statement? You know, most of the guidelines with which general pathologists are aware of have dealt with neoplasia. And when they decided to go ahead, HER2 guidelines, we all know about this, ERPR guidelines, very important things. This is one of the first guideline statements on non-neoplastic disease. And it was a little bit like getting a square peg into a round hole, but we struggled through it. I'll take you through the process. I'll invite you to submit ideas to CAP for evidence-based guideline development. I'm going to emphasize the guidelines and how they relate to ultrastructural analysis and talk about the future role, if any, of EM in the workup, the routine workup of amyloidosis specimens. Can't start an amyloid talk without talking about Dr. Virchow and Dr. Schleiden, who in botany and human tissue were first to identify this starch-like material in plants and human tissues. They used the Lugol's iodine stain, which is iodine sulfuric acid, which sometimes I do it at gross autopsy conference, and it's kind of, ooh, but we don't do that anymore. But that's how amyloid was first identified. Here's the picture of Dr. Virchow. I didn't want to leave him out. This is a lovely review of basically the role of very advanced imaging technologies in the identification and characterization of amyloidosis. The proteinaceous nature of amyloid was identified by Friedrich and Kekul, and they took tissue homogenates and found with amyloid and found a very high nitrogen content. Actually, Virchow suggesting this was a protein being deposited, and Virchow actually disagreed with that. He said, you're using whole tissue, how do you know, etc., but ultimately proven true in large part by the use of electron microscopy showing structure, etc., that amyloid was a protein, and more than 50 different proteins have been identified now. And here you can see all the cool things that I know nothing about and don't do, but that are contributing to our understanding of the pathology and pathogenesis of amyloidosis. Back to real-world everyday pathology. What are the new CAP amyloidosis guidelines recommending regarding ultrastructure? My dear friend, Dr. Miller, who wrote the paper with me, taught me bluff, bottom line up front, not much. I'll try to show you why that is and convince you that we can change that. The guidelines, what we did. A panel of experts was convened to develop a guideline using the National Academy of Medicine standards. Now, many of us have been in subspecialty societies where we say, this is best practice, but you're not following evidence-based guidelines all the time with systematic reviews, etc. The CAP Guideline Center is all about evidence-based. Whenever we go see a physician these days, high blood pressure, hypercholesterolemia, they're following evidence-based guidelines to treat us. And that's what the CAP is trying to standardize in terms of pathology evaluation of specimens. So the center is a forum to create and maintain evidence-based practice guidelines for pathologists on best available evidence and expert consensus opinion. They're open access guidelines. They're not supposed to be prescriptive or restrictive, but just general guidelines. You don't have to, but this is supposed to be best practice. You can see here the amazing group of individuals that we got together to help us, including our dear Dr. Herrera. Dr. Picken was also part of this group. We had a medical librarian as a data analyst, who is Leslie Suter, a PhD, a remarkable woman, and a medical librarian helping us. So that was really amazing. Why now? We all know that there are new imaging techniques for cardiac amyloid. So as a cardiac pathologist, they want me to diagnose amyloid as early as is humanly possible and to confirm or not confirm imaging findings. And there are newer therapies for amyloid, as we all know, so we can impact the quality of life for these patients. So this is becoming a very critical diagnosis for us to make. And the CAP had identified variability in the laboratory diagnosis and further classification of amyloidosis. So they approved it. The CAP CSA, the scientific group, approved this. So after they approved it, we formed the panel. Developed scope and key questions, researched and reviewed evidence, drafted recommendations. There was an open comment period. I don't know if anyone had the opportunity to review the guidelines and to comment on them during that time, but then we reviewed the open comments. We made the manuscript. It's officially published March 2026. And then ultimately we're going to maintain and monitor the guidelines. We'll either reaffirm them, update them, or sunset them. I doubt they'll be sunsetted. What was the scope? Laboratory evaluation of amyloidosis specimens and fibril typing. The key questions have to be structured in a particular way for these studies. We call it PICO, Population Intervention Comparator and Outcomes. And the expert group argued a lot about these. What population is this key question addressing? What's being done to the population? What's the intervention being compared to? And what are the outcomes? Outcomes are a bit difficult to decide on. These were the key questions that we came up with, which you can see in patients. And by the way, no CNS. We weren't in amyloidosis, but we were otherwise tissue agnostic. So in patients with suspected amyloidosis, do surrogate biopsies work as well with diagnostic sensitivity as target organ biopsies. I'm focusing on key question 2, which is where EM only popped up. In patients with suspected amyloidosis, what method most accurately and reproducibly detects amyloid? Can you do fluorescence microscopy to improve sensitivity versus light microscopy and cross-polarized light microscopy? Cytology, can you do cytology? Is it equally sensitive, specific? What about FFPE? And then 5 and 6 were both protein subtyping, and these were controversial, as you might understand, regarding the use of mass spectrometry. 5 was IHC versus mass spec, and 6 was immunofluorescence versus mass spec. And definitely in kidneys, everyone agrees IF is good and great. Nobody's saying not to do it and that you have to do mass spec on everything. But in other organs and tissues, mass spec does appear to be having a role. You'll notice there's no immuno-EM versus mass spec because there's just not evidence out there. And this is evidence-based. Going to go into a little bit more about KQ2. So you see the PICO, the population, cytology, histology, subgroups. We were, again, tissue agnostic except for not CNS. The intervention, all of these, including electron microscopy, Congo red with or without fluorescence, cross-polarized microscopy. Our outcomes, accuracy of diagnosis, diagnostic test characteristics, early diagnosis, overall survival, and pathologist concordance. Then we looked at the literature. And this gets in part to why EM is not so highly factored. It was a 10-year survey, 2013 to 2023. And we wanted to go back about 15 years, but CAP said we would basically almost double the number of references, and that might be cost prohibitive, to be quite honest with you. So I'm just explaining some things. They didn't actually say that, but they strongly encouraged us to limit it to the 10-year. we took 464 articles through abstract and title review, and then came up with 32 total articles that underwent full text review. The ones that were applicable to ultrastructure, cerebral nerve biopsy and hereditary transthyretin amyloidosis, EM Congo red concordance in 10 of 11 cases. The 11th case was diagnosed by EM and was a variant known to be typically Congo red, difficult to detect. Yamamoto in 23 endomyocardial biopsies, Congo red, EM concordance in 17 of 18 cases, and one light chain amyloidosis diagnosed by EM only. Again, immuno-EM too limited to compare. But, in the real world, EM is still very important. This is a fairly recent heart biopsy I had. Okay, the H&E is suspicious. The trichrome, is it blue-gray blue, Congo red, Mets and Mets? I didn't want to repeat it because I wanted to keep enough tissue. Even Congo red fluorescence, I have too much myocyte staining. I mean, this is just real world. Congo red polarized a little bit maybe. EM was confirmatory, and it was an AL amyloidosis by mass spec. And again, part of the reason so few articles, the time period, case control, observational, randomized controlled guidelines with and without meta-analysis. So in the end, KQ2, so the recommendations are based on the grade scale, and basically it's a strong recommendation, a conditional recommendation, and then what we call good mother statements. Basically, you should, if you're being good, do this. We had no strong recommendations for any of our key questions just because of lack of evidence. But the conditional recommendation was that you should use Congo red or any other method that is validated against Congo red or electron microscopy showing equivalency. Other key questions, again, as I said, conditional was the strongest we got. There were no strong recommendations. Cytology, definitely okay, easy, safe to do. You have to optimize your staining for cytology, and you have to be sure to understand that you're going to limit your ability to fibril type based on the amount of the specimen. Using TRITC fluorescence is definitely good with Congo red to increase sensitivity. When you have patients being considered for therapy with amyloidosis, to optimize diagnostic yield and tissue utilizations, pathologists should use mass spec to identify the fibril protein type. Again, mass spec is, and I'm not here advertising mass spec, but we all know who send it. It's a protein agnostic. You can get whatever you want. You can identify multiple protein types, etc. I personally think it's much more relevant in the heart and other organs than most of the kidney specimens that we can identify very easily by immunofluorescence and or immunohistochemistry. And I know a lot of you are not doing mass spec on your renal specimens, but I encourage you to publish what you're doing in your hospital so we have evidence to update and refine these guideline statements. When the good practice statements are they even less than conditional, it sounds silly, but it is the way we worded it. If you get a specimen for amyloid, do an amyloid stain that's validated and report what method you use in the pathology report. Not a concern for this group of people. If a clinical concern for amyloidosis persists after a negative surrogate biopsy, you can recommend target organ or go back and look at archive specimens. And that pathologist should determine the fibroprotein type. You would be surprised to know that we had open comments in the open comment period that pathologists should not be responsible for fibroprotein typing. And I was shocked by that, and I didn't think it was very good practice. So if the guidelines seem silly and simple to you, there's a reason for it. We have to get the baseline up to appropriate patient care. What's the future for EM? I think looking at the effects of these newer therapies, ultrastructure, I, for one, really want to know what happens after we do some of these antibodies to the amyloid. What do they look like ultrastructurally? I don't know. I'm very interested in if anyone has any autopsy tissues or anything of patients who have been treated, because these patients are being treated now. Collect this tissue, look at it ultrastructurally. What's happening with the oligomer? How is amyloid injuring tissue? We know a little bit about it, but not a lot about it. And EM is very vital in this way in terms of research. In terms of the guidelines, publish what you do in your laboratories. A lot of you are very comfortable doing IHC, IF, etc., plus or minus mass spec, plus or minus EM. Please report what you are doing so that when we go back in 5 years to look at the evidence again, that we have evidence and data to get evidence-based guidelines out there. Thank you so much. I really appreciate it.